Okay, let's look at this particular substance use case. This is another vignette about Stephen, who is a 35-year-old surgeon. So let's find out a little bit more about him. It looks like he's in a local group practice, joined about 4 years ago after finishing residency. Looks like he grew up in a lower middle class family. 5 brothers and a sister. Father was a skilled laborer. Never really had much money, and Stephen put himself through college and medical school. So as a result, it looks like he owed over $125,000, which probably back then is a lot. Nowadays, I'm sure it's a heck of a lot more. He goes on to meet his wife. They were married when he graduated, so then she works as a secretary for 3 years. So she's kind of doing that. Their combined salary is enough to pay living expenses and the interest on his loan. So, yeah, that's a good thing. It looks like a son was born during third year of residency, and then a daughter was born 2 years later. So we have a lot of biopsychosocial stuff going on. Probably the predominant thing then right here is just it's a lot of kind of issues about money, right? But it sounds like they were enough to pay their living expenses, even as they start kind of a young family. However, it looks like the second child, after she is born, it looks like they're more concerned about making money to pay off loans and support the family. It didn't allow him to moonlight the training program. So he started to decide to invest in risky but potentially lucrative financial enterprise with one of his friends. So kind of starts to go out on a limb and risk some money here to earn some money. So he had no difficulty borrowing several $1,000s from a company that specialized in making loans. So it sounds like he was able to get the credit to do that. And it looks like he made 10 grand in that first year, so which he used to pay a down payment on the house. So then he finished the training, joined a practice. So everything seemed to appear to be going pretty good at that point. So essentially we have a ton of just biopsychosocial, but as we can see, like the main theme of all this is financial. Kind of, it doesn't really say though a whole lot that he was distressed at all. It makes me stressed just thinking about it. But looks like financial kind of issues are the big thing in this first portion. But he did well in his first practice, loved surgery, respected by patients' colleagues, began to pay off his loans. So, I mean, this is kind of ideally got back on track, bought 2 new cars, furniture for the house, invested more money. So things kind of start to go back in the right direction. So this first part of the scenario really just kind of maybe teases out that there's kind of this financial issues. There's not a whole lot of kind of symptomology here. It doesn't even really say that there's a whole lot of stress other than saying becoming increasingly concerned. But other than that, doesn't show any sort of deep anxiety or depression or anything. It sounds like he, although made somewhat risky investments, kind of came out on top. Doesn't say that caused any sort of distress either. So let's go on to the second part and see what comes out of this scenario then. Okay, so the scenario goes on, and suddenly he had money for everything he wanted. So this is kind of, I think, for some who go to med school, this is kind of what they've, in some ways, dream about. Probably beyond medicine, it's the hope that you start to make some really good money once you've paid the loans off and that. So you start to kind of live that life that hopefully you've kind of dreamed about as far as being financially independent. So this is the first time it says in his life that he felt free and financially secure. So sounds like as far as maybe mental health wise, as well as financially, doing pretty good. Looks like him and his wife started to kind of hobnob and become part of a group of young, kind of wealthy professionals. And it says they started who lived a fast fast and seemed to have unlimited amounts of money to spend on new cars, houses, foods, and here we go. This is the key right there, food and drugs. All right, so you start to get a bunch of young people where they're able to throw around money, and then there's this kind of substance use that kind of gets introduced into this scenario. So it looks like Stephen began to feel pressure to be accepted by his new friends and keep up with them financially, which I would say is kind of typical. You start to run in those circles, got to keep, as they say, keep up with the Joneses. So you got to spend money, you got to pay to play, as they say. So felt like there's a feeling of pressure to be accepted. So here comes kind of maybe some stress or stressors where you start to feel pressure. He worked hard over the next 3 years, practice grew, invested more money in risky investments. So kind of that can increase anxiety sometimes depending on the personality, but risky investments that provided high return he needed to support his new expensive lifestyle. So it sounds like, at least as far as financially though, even though he goes out on a limb with some risk, it seems like it pays off. And at this point, looks like it was able to support his habits, so his new lifestyle. Soon he acquired all the personal possessions and trappings of a successful physician. So here we go. This guy's living the high life as far as finances and everything, but it kind of teases out this idea that he's now rolling in circles and living a lifestyle that involves spending money, and then it teases out that little part of drugs, which we'll see how things play out. So it looks like the fourth year of practice looks like his luck changed. So let's find out what that means. It looks like economic recession happens, produced a reversal in his financial affairs. So this almost sounds like 2008 for those of you who kind of remember that. Kind of financially, everything went upside down, right? So there's a reversal in financial affairs. He lost a substantial amount of his money in his investments. So this is where, for a lot of people, when they thought they were set and secure and had a lot of money, all of a sudden this downturn, people lost kind of half of what they thought that they had in their investments. So it looks like he responded by working harder in his practice. So as far as the resiliency factor, he kind of puts his nose to the grindstone, goes back and really works hard. But his wife and coworkers noted subtle changes in his behavior. So I'm going to highlight that. Let's find out what these subtle changes are. He became moody and irritable. So I'm going to change this. So here we start having symptoms. Moody and irritable, which, to be honest with you, I mean, moody and irritable, given the scenario, I mean, that for men, for males, oftentimes depression can come out in kind of irritability. Moodiness, anxiety also can bring on irritability and stress, which can cause people to be edgy. So moody and irritable, I mean, it could be in the realm possibly of bipolar. I'm just going to throw that out there as just to include it in a differential, but we've still got a little ways to go as far as kind of manic type of symptoms, but we'll throw it out there because it's a potential differential, right? Because of the moodiness and irritability, certainly that kind of goes along with it. So, and at this point, because of the kind of going back here to the drug use, we always have to ask ourselves in differentials as well, is it due to a substance? So that's going to be in play also. So here we go, moody, irritable. Sometimes he was alert, full of energy, and almost euphoric. So, this is kind of interesting, because now when I was just thinking like, we got a little ways to go for bipolar, certainly this idea of euphoric, more energy, kind of increased alertness. certainly that's more along the lines of bipolar as opposed to depression. You're not really full of energy, euphoric, and alert. So actually bipolar's kicking in a little bit more. And again, you still at that point also have to be more aware that it could be due to a substance, especially if it's more kind of a rapid onset or acute onset. He's 35, I believe, so I mean, at this point, this is kind of quite a ways, I mean, as far as bipolar standards, this is quite a ways into a 35-year-old male, when typically kind of bipolar signs and symptoms similar to schizophrenia are going to come on usually in kind of late adolescence, and for sure within kind of the early mid-20s for males. It's really going to show up. So the idea that kind of this really didn't play out in the early part of the scenario when he was going through med school, stuff like that. Yeah, he had some risky investments, but really didn't speak to anything as far as mood fluctuations or bipolar incidents. But here we go. He's kind of running in these circles. There's a downturn in the market, and now he's becoming moody, irritable. Now he's full of energy and euphoric. So you've got to consider bipolar, but there are some contraindications for that, like I said, because of just context and history. So we'll keep substances in mind because of the acute nature of it. At other times he was angry and sensitive. So here we go back to this concept of irritability, and he's sensitive to the slightest or imagined criticism. So again, this is pretty kind of characteristic of bipolar as well, kind of very sensitive to criticism. They can get angry, especially when people like question them on their grandiosity or some of their mood fluctuations or call them out on it. That can be pretty characteristic of bipolar. And again, if a person's using substances, if any of you have known a person who is currently or has been using substances, certainly the irritability or being on edge if they're ever criticized or questioned, certainly that could be part of substance use as well. Let's see. And then it says he was angry, sensitive to the slightest actual or imagined criticism, or he was depressed. So we'll just kind of highlight that as well. He seemed to be losing weight. Okay, so we have weight loss. Wife sometimes hears him in the bathroom vomiting. So those are kind of some interesting characteristics of weight loss, vomiting, which makes you think, also, is there some sort of medical condition? Or is it due to a substance use? If any of you, for example, those who nicotine can definitely cause weight loss. If there's any sort of stimulant used, methamphetamines definitely causes or can cause weight loss, cocaine, any of those stimulants. So certainly we're kind of in the running as well. Bipolar, again, this idea of kind of weight loss with bipolar, I guess, unless you're like staying up and not eating right and the grandiosity or racing thoughts are kind of taking over appetite in that, but that's never really something I've heard as a common symptom of bipolar as far as losing weight, vomiting, stuff like that. So that's kind of questionable as far as bipolar as a kind of a driver of this. Certainly a medical condition or substance may be something a little bit more related. So looks like the operating room staff, knowing that he's a surgeon, looks like they start to complain that he behaved erratically during operation. So this is certainly critical in the sense that I might as well continue on after exploding and yelling at the staff. So as we can see right here, now we have impairment in work environment, especially if you're erratic during operations. I mean, geez, that's kind of the last place that you want to be starting to become erratic, both for the patient and for the staff. So impairment in work, you could even include kind of social, because I mean, if you're starting to get erratic with your staff, and then the way you behave at work as far as the operations, as far as the efficiency, effectiveness. So as far as the DSM is concerned, we're starting to kind of go down this route of meeting the impairment kind of criteria. His wife becomes concerned about his behavior and depression. So certainly she knows and can see that his behavior and depression's kicking in. The driver behind that then, so we've kind of had these mood fluctuations for sure. Irritability, increased energy, which can certainly be due to, like I said, it certainly could be due to kind of maybe bipolar-ish. That it could also be due to a substance. As we know, if and when you start to withdraw from any sort of stimulant, for sure, you're going to kind of hit the skids, and depression's going to be part of the withdrawal process, to where your body wants more and is going to crave more. So she can see kind of these mood fluctuations. He responds to her questions with irritation and curt, superficial comments. So we even start to get kind of impairment in relationship going on. So we've kind of met the criteria as far as multiple areas of something impacting him. Finally, Stephen's colleagues become concerned. So now we even have colleagues questioning his behavior, insist that he see somebody for a professional evaluation. So everybody's concerned about all of these symptoms that we're seeing, which again we've kind of touched on a whole bunch of different potential differentials, I would think, that are in the ballpark of these type of symptoms. Reluctantly, it looks like he made an appointment to see a psychiatrist. In the interview, first interview, it looks like he was elated and depressed over the last few months. So again, the mood fluctuations going on. When depressed, his sleep was poor. With vivid, unpleasant dreams, his appetite was poor. So these could also be, this could also then be characteristic of substance withdrawal. When there's a depression, or with you're withdrawing from any sort of stimulant, in this case, that could be the likely cause then of all the substance uses or substances. Kind of that would be the most probably probable, if we were to include that, would be a stimulant. This kind of up, alert, energy, euphoric, and then a depression during the withdrawal stage. Poor sleep, unpleasant dreams, and poor appetite, which would explain kind of a stimulant issue if that's the case. He lost 9 pounds during that time. The psychiatrist inquired about other details of his life: medical illness, suicidal thoughts, stress at work, drug and alcohol use, and his relationship with his wife. Looks like he answered some of the questions directly. Let's see. Some questions directly and dismissed others as irrelevant. He seemed irritated with the interview. So irritability again. Became impatient to leave. When the psychiatrist asked him about drug use, Stephen seemed insulted and laughed, which would be kind of common in this case if there was drug use. Kind of this denial phase of like, no, that's not me, or it's kind of playing it off. The psychiatrist pressed further. Stephen became angry, stating, I didn't want to come here. My partners forced me to. You shrinks all think the worst of someone. How much longer are you going to interrogate me? So becoming very, very defensive when questioned about drug use, which usually means you're on the right track. Most folks, I would say if there is any sort of substance use going on, it's deny, 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 which is actually kind of common human nature with a lot of things. If you're doing something uncharacteristic in your life or lifestyle, denial is usually where you go first, and then kind of you get called on the carpet. So looks like the very last sentence here is what's going to, looks like, show us where this vignette ends up. And that's the psychiatrist listened quietly and then asked again whether Stephen was using drugs. So good for the psychiatrist of kind of listening rather than badgering him, and then asked him point blank if he was using drugs. So good question. Stephen was silent, looked down, and slowly nodded. So there we go. That's in the very last, we read through that whole thing to come down to the very last sentence to where, here we go. So that's kind of, so we have confirmed use of substance. Okay, so where do we go from here? Well, that kind of helps us for sure, right? Because at this point, we can go back up to our differentials. Certainly, can we say that these are signs and symptoms? Yes. What have we learned about the differential diagnosis process, though? Hopefully, you've learned by now that the first steps in that is if it's due to a substance, then that's kind of where things taper off, short of him having previous depressive episodes or previous diagnoses or episodes of anxiety. That's when it may be more of a comorbid disorder, where it would be the mental health disorder and a substance use disorder. But in this case, we really don't see anything that says that this gentleman, Stephen, had any sort of mental health previous diagnosis or significant episodes of anxiety or depression. So I'm going to go in the direction that this that we're actually dealing with a substance use issue. It doesn't appear to be a medical condition. It sounds like the psychiatrist asked him, and I'm assuming. We don't have evidence that there was any sort of medical condition that was causing the weight loss. So I think we definitely on the right track by saying it's a substance of some sort. He admits to it, which is kind of what we need for the DSM, is this idea that, yes, he indeed is using some sort of substance. The idea that it increases his energy, euphoria, irritation, that type of stuff. That would be pretty typical of all the substance uses. I'm looking here in the DSM. Of all of those, typically we're looking at the characteristics of a stimulant use disorder as far as that type of characteristics. Energy, euphoria, and then when there's withdrawal symptoms, we start to experience the depression, the irritability, the weight loss, the poor sleep, those type of features. So I think we are on the right track. I'm just looking at the DSM here in the stimulant withdrawal. Let's see. So let me look at the stimulant intoxication really quick. So we're looking at nausea or vomiting, evidence of weight loss. Looks like psychomotor agitation. It didn't say much about heart rate or pupil dilation, but we definitely have two of the following at least: nausea, vomiting, weight loss, kind of agitation. So we definitely have those instances of kind of intoxication. We can kind of see those signs. We also have, let's see, euphoria, changes in sociability, hypervigilance, interpersonal sensitivity, anger, somewhat anxiety, impaired judgment. So I'm going to go out and say that, yes, we've kind of met this idea of that it's a stimulant. Kind of, he's had moments of intoxication because we can kind of match that up with the symptoms. We wouldn't diagnose him as currently being intoxicated, which is what that diagnosis requires. We're talking in the context of current. But we can tell that the intoxication matches up with the stimulant based on that criteria. And then the withdrawal symptoms, we can see that there's vivid, unpleasant dreams, either insomnia or hypersomnia. And then it looks like appetite issues and psychomotor retardation or agitation. So he also meets the criteria as well for the withdrawal symptoms. So we kind of we also see that it says dysphoric mood, right? So that depression. So there we go. We can tell that he's kind of going through cycles of intoxication and withdrawal. And because neither of them appear to be kind of that's this current issue, we don't have a lot of information. So it speaks broadly to a pattern, which is what we need to establish a use disorder, meaning that it's kind of an overarching theme in that he's using some sort of substance, in this case some sort of, so I'll write it down, it matches some sort of stimulant use. Now here's where things get tricky is with stimulant disorder, let me jump back here real quick. In stimulant disorder, we either need to identify, in this case in the DSM, we have to identify whether it's an amphetamine, usually methamphetamine, right? Or cocaine, which is another stimulant. And then it says other unspecified stimulant. So in this case, here's the difficult thing, is at the very end, he says he's using drugs, here we go at the very end, but never identifies what it is. So what is the diagnosis? What's the best thing to do here? So in my view, we have that it's some sort of stimulant, but he never acknowledges it, which is what's required in the DSM in order to at least meet some sort of criteria to that effect. But because he doesn't admit that it's a stimulant, we only can go out and kind of assume based on kind of the characteristics, if that makes sense. He doesn't really mention what it is. So in this case, here's my suggestion. Here's what I would come up with is the fact, and you've probably already. So what I would go up with or come up with is actually the very end, where this might be a case of unspecified. So let me see if I can write it here. So this would be kind of a case of unspecified stimulant related and then most likely at this point, because you have no confirmation of exactly what the drug is or if indeed it is a stimulant, this is where things become touchy because, or kind of the issue is because you can't identify it as a specific stimulant. All we can do is match it up with the characteristics. So it's almost we're stuck having to say that, yeah, it's unspecified stimulant because we don't know what it is. But we also, in my point of view, have to mark it as provisional because, once again, we don't even know if it's a stimulant. We just know that it's a drug and it matches up with stimulant characteristics. So hopefully that makes sense. And I think this is kind of a good example of where we need to kind of slow ourselves down and objectively kind of walk through and make sure where we're at with the diagnosis. So it says here at the very end, we're on page 644. Looks like the code for this, for unspecified amphetamine or other substance-related disorder, is F15.99. So I'm going to put that up here. So F15.99. But again, I'm going to put that, but then put kind of provisional. You could go out on a limb, I think, and just and put F1599 as unspecified stimulant. You could probably get away with that without the provisional sort of in parentheses. But I would put that just to be kind of safe, because again, if they said, well, how do you know it's a stimulant, and you kind of shrug your shoulders, all you can really say at that point in your defense would be, well, the characteristics match up with some sort of stimulant. And then again, they beg the question, well, how would you know, if it was exactly that? So that's when this is a good example of unspecified, because we're not quite meeting the exact criteria of the full substance use disorder either. We don't see a lot of patterns of him spending time seeking out. We don't see a whole lot of kind of tolerance issues. All of those things that would be required in a use disorder that we need to meet. So that's why it necessarily wouldn't even meet a unspecified substance use disorder, is because we're not even quite knowing about tolerance. We're not knowing if he's taking kind of larger amounts over longer periods of time, unsuccessful efforts to cut down, so cravings, desires. So if you can see where that's at, is I couldn't even justify going down an unspecified substance use disorder, or a stimulant use disorder, other or unspecified stimulant, because he's not even really meeting the criteria of a substance use disorder. So you almost have to go to an unspecified, because that allows us to say, well, he hasn't met the criteria. It's signs and symptoms of some sort of stimulant. It matches up, but even then we can't and don't even know. So we'll put it as provisional. Hopefully this was helpful to kind of see how to maybe sort out what an unspecified diagnosis might look like and why. And then even at that, being able to put provisional, because we just don't even know. If he were to come out and say, I've been using cocaine or whatever, that would at least give us some sort of direction, and we could go back into the cocaine usage. And even if that's the case, we can say the ICD-10 gives us an unspecified cocaine-related disorder, or even if he says, yes, I've been using meth, we could do an unspecified amphetamine type. And we would need to do unspecified just for the fact, as I just said, he hadn't even met necessarily the criteria for a use disorder yet. We would still have to go unspecified at that point. We would have enough, though, to make the unspecified without doing a provisional, because now we do have an identified substance. Wow, there's a lot there, right? Hopefully you understood that. If you have any questions, let me know. But this is a great example of how to kind of sort things out and walk through a potential unspecified diagnosis. There you go.